Thanks so much, Dr. Kessler and Dr. Silla, for the invitation. I'm going to go through kind of a little bit of whirlwind here, updating on the current literature. I have no relevant financial disclosures. So today I'm going to run through the general adoption of MIS in the United States. I'm going to talk about some patient-specific factors as well as hospital-specific factors that seem to affect adoption. I'm also going to talk about geographic distribution, center volume, conversion rates, adoptions by our younger surgeons, and then I'm happy to report that on my flight over here, my statistician did get the data updated in time, and so we have some very current data from the most recent national inpatient sample on what's actually being done in the United States today. So, adoption of MIS colectomy in the United States has actually been slower than one might expect based on other minimally invasive procedures. And there's been questions as to whether or not this is due to the learning curve or the large amount of lower volume surgeons that participate in MIS colectomy, or there's questions about whether or not this is due to partly the role of cancer and concerns about whether or not laparoscopy was safe for cancer before the COLOR trial. As you see from the figure below, compared to appendectomy or cholecystectomy, laparoscopic colectomy has had a much slower uptake. However, recent data published this year in the Journal of Surgical Research shows that actually over the last 10 years, there's been an over doubling of use of MIS colectomy. This is through the NSQIP population, which, as most people know here, is a relatively selective population of more high-volume centers or centers with resources that they can participate in NSQIP. So it's not always representative of the community, but on a national level at NSQIP data, we're at about 50%. There are obvious patient factors that contribute to whether or not MIS colectomy is taken up. We're going to talk briefly about the Davis paper as well, where they looked at some of these patient factors. Patients overall across the 10-year data time have had an increase in uptake, while it's been slightly slower in the oldest age groups. Across all age groups and BMIs, there's been an increased intake. Looking at ASA level, not surprisingly, we see that the lowest rates of uptake are in the highest ASA levels, with ASA 4 in that yellow group there and ASA 5, the bottom blue line, being around 10 to 20%. And then, not surprisingly, MIS emergent procedures are at much lower rate than elective procedures, but still rates have doubled over the last decade. Hospital variation has been looked at in a number of different series, and as with many other technically challenging procedures, high volume and teaching centers seem to have the highest rates of MIS, and rural centers have lower rates of MIS procedures. When looking at geographic variations in the use of MIS for colorectal cancer, the Michigan group used SEER Medicare data in a publication where they actually found that the rate of MIS use for colorectal cancer is from 0 to 67%. So all of the facilities that they looked at had laparoscopic equipment available, but the range was quite significant. You can see from this map of the United States that a lot of the high volume centers, which are the darker, or a lot of the high volume locations where over 40% of the procedures are being performed minimally invasively, are more at larger cities and where there are high volume centers. A recent paper by Aquinas in Annals of this past year looked at the use of minimally invasive for neoplasia and cancer versus benign disease, and you will see that neoplasia and Crohn's disease have slightly lower rates than benign diverticulitis, and UC actually has some of the lowest rates of use of minimally invasive colectomy. Looking at center volume, about 4 years ago, our group looked at the national inpatient sample data, and we broke it down by what was considered low volume, mid volume, and high volume by tertiles. And you'll actually notice that the low volume actually includes places where 92 procedures are being done a year, which can actually be considered high volume in some situations. But we did see that in the higher volume centers, there was an increased rate of uptake of both laparoscopy and open procedures, and a decrease in some of the low volume centers, suggesting that there might actually be a change of patients going towards more high volume centers. Looking specifically at conversion rates, not surprisingly, in the earliest groups of conversion, the rates were higher. Initial publications, the initial codes that we can use to extract data defined a laparoscopic code in late 2007, so most of the studies here, as you'll see, start in 2008. So the early 2008 to 2011 data shows specifically that the conversion rate is much higher than we would expect right now in this early cohort, specifically noting right hemicolectomy here with a conversion rate of about 15%, and going all the way up to conversion of nearly 21% in the transverse colon. When they looked at hospital rates and factors for conversion, they found that emergency procedures, again, as we talked about before, and rural location were affiliated or associated with a higher conversion, and as in our prior data, also affiliated with open procedures. More recent data using the NSQIP data as well, just published through Colorectal Disease in 2015, showed a much lower rate. As mentioned, this is NSQIP data, so these are more of the high volume centers, but they showed that about 94% of the procedures were successfully completed in minimally invasive. If we look at these comparison groups, and this is smaller on the screen than I had hoped, but there are no surprises here. Higher rates of obesity, so higher BMIs have higher rates of conversion, and higher ASA class also has nearly a doubling of conversion rates. Smoking and ascites are additional risk factors, and patients who'd had significant weight loss, such as those who might be sicker, had a trend nearing significance. If we want to look more recently at the younger patient population, we see that the adoption by younger surgeons has actually increased as well. There was a recent study by Dispar et al. That wanted to look at whether or not people had gone through ACGMEA programs and what their current practice volumes were. So, do we have a pointer? If you look at the first group here, they asked the recent graduates from 2013 to 16 what percentage of their practice was constituted by different procedures. You'll see the first column here is hand-assisted, the second is laparoscopic, the third is open, and then the fourth is robotic. So this is across a cohort who took their colorectal fellowships between 2013 and 2016. You see that the majority of the cases are done minimally invasively, with actually a small minority, less than 18%, being performed as open procedures. Looking at this cohort over time, if you look at the group that graduated in 2013 to 2014, this group is actually the group that had the highest rate, had the highest number of procedures performed robotically. Over time, laparoscopy actually has increased across this cohort of 3 years, and robotically has gone down slightly, which I think was a little bit of a surprise when I was reviewing the data. So just briefly, I'm going to go through a few updated slides. These are from the most recent available year of the national inpatient sample. It takes about two and a half years to be available, so this is 2015 data. This is site-specific and unpublished data, but I did check it a couple times with my statistician on the plane ride over. So just looking at overall trends over the last 5 years, you see that there's an increase in laparoscopy and a decrease in open procedures, but we'll talk more specifically about the specific procedures themselves. So I know that this is a section that's focused on right colon, but I think it's important to have the comparators of transverse colectomy as well as left colon. So if you look at the right colon over here, you'll see that 51% of these were performed laparoscopically. These are, again, non-cancer related procedures. Transverse colon more open, and then left colon, the majority of these are done lap. This is the final slide. This is the final slide just to show the difference in cancer. We have the right colon procedures being the majority done lap. The transverse colon majority is still being performed open, and the left colectomy is a little bit of a split. So just to summarize the MIS Colectomy Conclusions throughout the United States, adoption is continuing to increase. Across all patient cohorts, we are having increases, although still in emergency setting, MIS is not routinely used. Hospital variation varies widely nationally, both on geographic and volume rates. Conversion rates have gone down, and it's much less in the right and sigmoid. Younger surgeons have increased their uptake, and from a site-specific range, MIS is still up on the upswing with less in the transverse colon. Thanks very much. Sorry, I'm a minute over.
This is great.